Thank you so much, and welcome to everyone else. Thank you so much for joining. So again, I'm Caitlin Turgeson. I am the pediatric allergy PA here at Valley. And today we're going to talk about pediatric allergies. So first, a little bit about me. You might be wondering, what is a PA? So PA stands for physician assistant. They're actually working on changing our title to physician associate right now. So you might see both of those things when you search for a PA. I am a medical provider. I can see patients, evaluate, diagnose, and treat them in the same way that a physician can. But I do have a supervising physician who I work with. We collaborate like a team. In the event that I have questions, concerns, like to run a complicated patient by him. So for those of you who are already familiar with our department, that person is Dr. Gatan. He works at Mount Sinai in New York City and also here at Valley in New Jersey. And then also I should mention that if you are more familiar with nurse practitioners, PAs are very similar to nurse practitioners rather. There are some different legalities and some differences in how we function and how we train, but a similar background. So just these two pictures down here, this cute little guy, I don't know, maybe he's going to be a vet, maybe he'll be a PA. This over here is me and my daughter. So for those of you who have logged on and are interested in learning about taking care of your children and taking better care of their health, I completely understand from a parent standpoint. So a little bit about pediatric allergies. So the things that I see and talk about every day. So food allergy. So I talk about things like peanut allergies and also less common forms of food allergy, things like FPIEs, if you've ever heard of that. We talk about drug allergy a lot. So for example, a lot of children come to me and have a diagnosis of a penicillin allergy. Maybe they got a rash when they had amoxicillin or Augmentin at some point in their lifetime. The interesting thing about drug allergy is sometimes you are misdiagnosed, meaning maybe you got a rash for a different reason, and that's why they diagnosed a penicillin allergy. Or maybe you've outgrown your penicillin allergy. This is really important because if we can clear penicillin allergies, which we can sometimes do after I talk with you about what happened to your child, we do some testing. If I think that it's unlikely that they're still allergic, we can do a challenge to penicillins. And the nice thing about that is if your child needs an antibiotic for a routine illness, I'd rather you use the Augmentin or the amoxicillin than need what we call the big guns, or bigger, stronger antibiotics that might not necessarily be the best fit. So again, someone that I would see is someone who has a penicillin allergy that wants to talk through it and potentially be cleared of that allergy. We're going to spend a lot of time during this talk focusing on environmental allergies. So most importantly, what's coming down the line soon is the pollen allergies. So we'll talk a lot about pollen, but also environmental allergies can include things like allergies to pets, dusts, mold, pests, things like that. I talk about hives a lot every day. So hives are itchy welts that people can get. Sometimes you just get a random hive here or there throughout your lifetime. I also see patients for chronic hives, meaning that they have these itchy welts that come on and last for 6 weeks or longer. There are different treatment options and different things that we would talk through, potential testing. So hives are something that we also see often in the pediatric allergy world. Other things down here, you'll see eczema and asthma. At the bottom of the page, you'll see the allergic triangle. So allergic rhinitis, which is really the fancy way of saying seasonal allergies or hay fever, eczema and asthma. So all of these allergic problems tend to go together. Eczema comes up a lot because not only can I treat mild eczema, but we also talk about eczema in the context of food allergy. Kids who have moderate to severe eczema are at a higher risk of having food allergies. And so this is something that I talk about daily in my practice. In addition, asthma can be triggered or worsened by environmental allergens like pests, pollens, etc. And so in addition to just treating asthma in general, we also have to work through with some patients when they have certain allergic triggers that can be making their asthma worse. So again, allergic problems go together. If you have one, it's possible that you could have another. You're more likely to have another. So when you come in for an allergy visit, we do talk through all of the allergic problems and address them to see if maybe your child needs some help in terms of one of those things. So pollen season ahead. So coming soon is March. Now we're all looking forward to spring. The only downside to spring is that we also have the pollens coming out. What a lot of people don't realize though, is that there's more than one pollen season. So the one that we think of the most prominently is the tree pollen season. So you'll see over here, tree pollen season, that's early spring. So the first thing that comes down the line, so March through May is when we see the trees blooming. You have green pollen all over your car in the morning that you need to clear off. That's when people have the most robust symptoms. So when you see that green pollen on your car, that's when people have the symptoms coming out. Later on in the spring and early summer, the grasses will become a problem for some people. Grass pollen allergy spikes between May and June. And then we have weed pollen allergies. So that would be late summer through the first frost. Now, the tricky thing about the weed pollens is that you can, this is when kids go back to school, right? So they go back to school, they're playing with their friends. We're wondering, are they sick or are they having allergies? Because they've obviously just seen all of their friends that they haven't seen all summer. They're being exposed to viruses, colds, illnesses, or did they have congestion for a different reason? The nice thing about allergy is that ultimately, if we tested your child, we could figure out specifically which pollen, maybe one, maybe two, maybe three pollens that they're sensitive to, and that would help us understand what time of year we'd expect them to have allergic symptoms. So for instance, a child that only tests positive to tree pollen who has congestion in the beginning of the school year, that's no longer tree pollen, right? Because those trees have bloomed and they are long gone. So at that point, then I would be thinking more illness if that child had congestion. What are some signs that what your child is experiencing could be allergy? So symptoms that I ask about when we're thinking about environmental or seasonal allergies. Eye symptoms like red itchy eyes, swollen eyes, nasal symptoms like runny nose, feeling stuffed up or very congested, sneezing. Breathing symptoms could be things like coughing or wheezing. And then some people will bring up skin symptoms to me. Like I bring my child outside, we play out in the grass, and they get a few hives. Or maybe they just have itchy skin at this particular time of year when mom or dad are suffering from seasonal allergies. And the other thing is if they do have eczema, maybe their eczema is flaring up around the time that they're having seasonal allergies. I wouldn't say skin symptoms are the most common, but definitely something that we talk about. And again, if you're concerned, it would be an indication to test for seasonal allergies or environmental allergies in general. So what are some signs that your child could have a pollen allergy? It's more likely to be allergy if the child is 3 years of age and older, if you've tried antihistamines like Benadryl, Zyrtec, Allegra, and they help, if these symptoms are worse when outdoors or shortly after coming indoors from playing outside, less likely to be allergy if the child is under 3 years of age, so younger kids. And antihistamines are not helping when you try them or you don't see much benefit. If the symptoms are the same whether the child has been indoors or outdoors. Now it's a little tricky because pollens are small. They can fly through screens. They're sticky. So if you have all of your windows and screen doors open, it is possible for pollens to come into the home and the child to be sensitized within the home. But again, in general, I would expect things to be worse when you're outdoors. Just a quick note, we will talk about the indoor allergens separately. The things that are never allergy, fever. So fever is never associated with a pollen or an environmental allergy, and other associated sick symptoms like vomiting or diarrhea. Now, let's just go back really quick to the age thing. I feel like some people might be wondering why I mentioned age. So it actually takes a few seasons for someone to develop a pollen allergy. So for instance, you have a new baby in January. In March time, when mom and dad are having itchy eyes and runny nose and using their antihistamines, maybe baby also has a runny nose. It's actually not possible for the baby to be allergic on their first exposure to the pollen. So this 2-month-old baby that has congestion it really should not be related to pollen allergy. Now, the age of 3 is a little bit arbitrary, but I'll explain. It usually takes about 2 or 3 seasons for a child to see enough pollen and for the body to realize, oh, I don't like that, and develop sort of defenses against the pollen before you develop those allergic symptoms. Now, have I seen kids who are like 2.5 that have clear pollen allergy? Yes. And have I had younger kids where parents are just really concerned? There's a strong family history of allergy. They just want to rule it out and want to do some testing? Yeah, absolutely. It's very straightforward. We'll talk through what testing looks like. But again, if your child is younger than 3 and you have concerns and want to be tested for these allergies, totally fine for you to come in for that. Just less likely that we'll find something, but not impossible. So again, how do we know for sure if it's allergy? We do a lot of talking. We talk through the clinical history, which is asking what times of year, what symptoms, what medicines we've tried, what helps, what doesn't. And then we do some allergy testing. So the in-office testing that we do is called skin prick testing. Skin prick testing is really nice because we get the answer in 15 minutes, whereas blood testing takes a couple days, couple weeks to come back. Now, skin prick testing, you do need to be off your antihistamines for it to work. So ideally for like 5 days. And the way that it works, I'll talk you guys through it. So you can see here is we essentially put little drops of water on the child's arm that contain a little bit of the pollens, the molds, the dusts, whatever we're testing for. And then we scratch it. It's not a shot, not a needle, not going to make the child bleed. Of course, anytime we do a test on a child, it can be nerve-wracking and they can get upset because we're holding their arm. But again, it's not a painful test. It can become itchy. I know that we will have one itchy bump. So I do put a positive control on their arm. That's something called histamine. Histamine, when you take Benadryl or Zyrtec, that's an antihistamine. So histamine actually should make a little itchy bump, like a hive. And that's a good thing. That means the antihistamines are out of your system, and that means my test worked. Then, if any of the allergens pop up, depending on the size of them, we would say that you may or may not have allergies to whatever it is. So if tree pollen pops up, dust, whatever it is, we would talk through what your results mean. And the size of the hives also weighs in. So if you have really large bumps to tree pollen and everything else is really small, I'd say, okay, I'm probably expecting this child to have worse symptoms in the March time, March, April, May, than the other times of year. So the other things I've sort of alluded to, but the other allergens that we test for. So we've already talked about pollens, dust. Dust allergy comes up a lot. Dust is not an allergy to the dust on your floor and the corners of your house. It's actually an allergy to dust mites. So dust mites, no matter how clean your house is, live in our pillows and mattresses. We are allergic to the dust mites, not the dust itself. You get a very hefty exposure of dust every night when you go to bed because you're in your bed for having a good night's sleep, hopefully 6 to 8 hours. And so the way that this allergy will present is someone will say, I wake up every morning with a stuffy runny nose and I sneeze or cough 5 times, and then I feel better an hour later. It's a daily symptom because, again, you're exposed every night in your bed, and it's not seasonal or cyclic in the way that pollens are. We would talk through, say your child tested positive for dust allergy, we would talk through precautions like putting dust mite covers on the mattresses and pillows. We would talk about washing the sheets in hot water once a week instead of just warm water. And then we would also talk about things like limiting stuffed animals, limiting rugs and upholsteries in their room. Molds come up a lot as well. Not so much like a little bit of mold in the corner of your shower. That's not enough to cause symptoms. But you can have mold symptoms if, for example, you're living in close proximity to construction, or if your child's school is undergoing construction. The reason for that is mold is kicked up in the soil. So if your neighbor is building an in-ground pool and they dug a huge hole in the backyard and suddenly your child is stuffy and sneezy all the time throughout the duration of this construction, could be related to the molds in the soil that were kicked up. We talk about pets a lot. So interestingly, a child who is born and brought directly into a home with dog or cat actually could be protective against allergy, meaning that kids who just come straight home and they have pets at home shouldn't have dog or cat allergies. Doesn't mean it's impossible, but it's less likely. But children have allergies to dogs, cats. Say your child goes horseback riding and they have allergy symptoms, or there's a class guinea pig and they have symptoms. We can test for those in other animals. And pests. So we're in the suburbs here. Obviously, cockroaches and things like that are a bigger deal in the city, but we do test for pest allergies. So, for example, if you have trouble with some pest and your child has been having a lot of allergic symptoms, it would be very reasonable for us to test for that. The other important thing about pests, um, along with the other environmental allergens, is if your child has asthma or breathing troubles, these things could be contributing to their difficulty in terms of asthma. So it's important information for us to know and to pass along. If you see a pulmonologist, they might want that information as well. So what are the treatment options? So we'll just talk through some of the treatment options. First thing we'll talk about is antihistamines. So I think, the ones that we like are things like Zyrtec. We also have patients who use Claritin, Allegra, Xyzal. A lot of families feel most comfortable with Benadryl because Benadryl has been around for the longest and most people are familiar with it. But I would actually steer you away from Benadryl. The reason is Benadryl only lasts 4 to 6 hours and it makes you sleepy. So if you think about it, if you send, your child is having pollen symptoms, you want to send them to school with an antihistamine on board so that they are not itchy and sneezy at school. If you give them Benadryl in the morning, now we're sending them to school with the potential that they might be drowsy for the first half of the day. And because it only lasts 4 to 6 hours, it might wear off by the time they go outside for lunch or recess or gym class. So we've sort of made them too sleepy to participate in school, and then they might not even have the benefit of the antihistamine by the time they go outside. So for that reason, I really like and recommend Zyrtec because it should last 12 to 24 hours and it shouldn't make them sleepy. There is a small percentage of people who do feel drowsy with Zyrtec, in which case I would advise that you would give it to your child at night because again, we should have a long time of coverage from it. So that should still last us through the next day. Also should note that, we can toggle with some dosages. So for example, your child has tried an antihistamine, it doesn't seem to be working. We have room in the allergy world to tell you to go up on those doses. Obviously, most families don't feel comfortable doing that. They're going to do whatever it says in the box, but we can talk you through how to increase the doses and when that would be necessary. Eye drops come up a lot because, like I said, a lot of people have red itchy eyes or swollen eyes with their allergy symptoms. The ones that I like and recommend are Zatador. It comes in an orange box. Alloway, think of the word as saying allergy go away, or Pataday. There is a stronger one that we prescribed until fairly recently, and that's called Pataday Daily Extra Strength. This eye drop is the strongest of the over-the-counter eye drops. It can cause some burning, so I do try to avoid it in younger children. But older kids who can understand that, okay, it might burn a little bit, but then it will be more effective, it can be really useful for them, and also for any adults that are listening. Nasal sprays come up often as well. So something like Astapro is an antihistamine nasal spray. Some families really like it and it works well for them. If that is not doing it, then I tend to recommend Flonase. Flonase is a very, very low dose steroid spray that we put through the nose. I like it because it does decrease swelling in the nasal passages over time. And this is one of the few allergy medicines that does need to be used every day to work. So it's not like you take a spray of Flonase and should expect your nasal passages to open right up. It takes a few days to kick in, like maybe 5 days to a week. And then consistent use is how we would decrease that inflammation and that swelling in the nasal passages over time. So if you've tried the antihistamine nasal sprays and they're not working, I would switch over to a Flonase, give it some time, be consistent, and you should see effect. What I do not recommend in children is Afrin nasal spray. Afrin can open you up right away. So if you're like, I need to clear my nasal passages, it can do that. But the trouble is there can be rebound effects. So if you use too much Afrin, you can start to have rebound congestion. So it can actually make your congestion worse. So I absolutely do not recommend that in children. Asthma medicines, if indicated, so some kids have asthma year round. Some kids only have asthma symptoms like significant cough or wheezing during the pollen seasons. Depending on what's going on with your child, they might just need some asthma medicines to get them through the season. So that might be things like albuterol or inhaled steroids. There's also a pill, an oral medicine called Singulair, which was originally an asthma medicine that we found had really great cross coverage for environmental allergies. There are pros and cons to that medicine, but it is something we can add on to your other regimen if your child is still having breakthrough symptoms despite that. The other treatments rather. If severe, we talk about allergy shots. Allergy shots are not something that I offer at my practice, but there are lots of great community allergists that we do refer out to. Allergy shots are something that you would use as a last line. So your child has maximized their doses of antihistamines. They've tried the eye drops, the nasal sprays. They're using everything correctly and properly. We've tried adjunctive medicines like Singulair, and they're still just not able to go outside and play baseball in the spring. That's a problem. We want them to be kids, and we want them to enjoy themselves and play and be able to be outside when there's beautiful weather. So that would be an instance where maybe we talk about allergy shots. Another person, maybe older kids who want to pursue allergy shots because they can understand it a little bit better. Alternatively, think of the college student who wants to be a veterinarian. They love dogs and cats, but they're highly allergic. That would be someone who I would recommend get allergy shots. But it's not a slam dunk. It doesn't always help. And it's 3 to 5 year commitment of first weekly, then monthly shots. So it's not a small thing that we recommend for children. Now, we've talked a lot about environmental allergies and seasonal allergies, and that's really where this talk was geared because we're heading into the pollen season. But I did want to answer a few questions about food allergy for anyone out there who has a specific interest or question about food allergies, just so you kind of understand things that we do here. So again, a little bit about pediatric allergy. This is the slide we saw earlier. Now we're going to jump into foods. So I get this question a lot. Who should be tested for food allergy? So the group of people that should be tested, there's 3 groups I'm going to mention. Anyone who's had an allergic reaction to a food. An allergic reaction is any adverse reaction to a food. So maybe your child ate something and they had hives, a swollen itchy eye, they threw up, they had coughing, wheezing, whatever it may be. Any reaction to a food, it is totally relevant for you to come in and have allergy testing and talk through what happened with your child. Second group of people who should come in for allergy testing are children with moderate to severe eczema. Now, moderate to severe eczema is something that we figure out based on talking to you and looking at the child. So the way that we qualify eczema is how much of the body surface area is involved, what strength of topical steroids or medicines have you used, has the child had skin infections, and things like that, and other things that can be affecting the child's quality of life. So kids with moderate to severe eczema are at a higher risk for having food allergies than the rest of the general population. And so those kids, it's totally appropriate. Pediatricians and other allergists send them to us all the time so that we can talk through those different foods and potentially do some testing before the introduction of allergenic foods. Now, the last group of people that I would say I most commonly see who come in for testing is people who have a family history of food allergy, meaning mom or dad or brother or sister have food allergies, and there's some understandable concern and worry about introducing allergenic foods in these children. So if you are nervous to introduce allergenic foods because of a family history, or you just don't feel comfortable or whatever it may be, this is someone who I would bring in. We would talk through the history, talk through specifics on the child, and decide if allergy testing is indicated. Sometimes we do, sometimes we don't, but there's always a big conversation around it. So definitely someone that I would like to meet with. Is allergy testing reliable? So this comes up a lot as well. Now, allergy testing is not perfect. There are a lot of false positives in allergy testing. So we try to be very thoughtful and careful about who we test. Now, if allergy testing were perfect, then every baby would be born. We would send them to the newborn nursery, get a whole panel of allergy testing done with their blood work, and I would know that this baby is going to have a peanut allergy one day, this baby is going to have a milk allergy one day, etc. Again, it's not so perfect. So essentially, we test people who are in those high-risk categories that I mentioned before, or if there have been specific concerns or if they have moderate to severe eczema, etc. So we try to be very careful. If the testing comes back and it's unclear, so maybe the numbers are low on the blood or skin testing, and we're not quite sure if your child is allergic to a food, we do offer an oral food challenge. A food challenge is something where we feed a full serving of the food in the office over about an hour, and then we watch the child for 2 hours. And of course, we're hopeful, we offer this because we're hopeful that the child is not allergic, but there is always a risk, given the slight positive testing, that they could have a reaction. So that's why we are there. We have a staff with us, we have medications available just in case. And so that's really the gold standard test in food allergy. Now, if your child is eating peanut butter every day and they love peanut butter, the best test for allergy, like I said, is a food challenge. So if they eat peanut butter every afternoon, that is a food challenge that they're doing. They are not allergic to peanut butter. Now, how do we manage food allergy? So the way that we manage food allergy is we avoid the food that you're allergic to. We educate families on how to sort of approach this allergy in terms of how do you treat in the event of an allergic reaction? How do you use emergency medicines? We show you how to use emergency medicines, and we talk through what an indication will be for using emergency medicines every day, or every visit rather. And then if we can, there are some treatments that we can offer. So that's my last question here, which is, are there treatments for food allergy? And yes, there are. You do need to be eligible, by which I mean that for each treatment that I'm going to talk about, there are lab tests that we have to do to make sure that your child will tolerate this. The first thing that we have recently started doing at Valley is something called Xolair. Xolair is an injectable medicine or a shot that has been around for a very long time for asthma. They realized that the kids who had asthma and also food allergies, who accidentally ate the foods that they were allergic to, didn't have as severe of reactions, or potentially had no reaction at all when they accidentally took a bite of the food that they're allergic to. So this led to a lot of big studies that got Xolair FDA approved about a year ago for the treatment of food allergy. So again, it is an injection, so it's a shot. Your child might need 1 to 3 shots every 2 to 4 weeks, and they need to stay on those shots in order to continue to be protected against these foods. But it's pretty amazing. And if your child is avoiding a lot of foods or really significant foods like milk, wheat, peanut, other foods, things that come up every day, then they would achieve some protection against all of these foods. We don't tell you that you can go ahead and eat your allergens, but it's just a protection in case you accidentally take a bite of something that we expect it should increase the threshold that your body can tolerate. So that little bite hopefully will not elicit a reaction, or maybe if it were going to elicit a reaction, it wouldn't be quite as severe as if you had not been on the Xolair. The other treatment is something called oral immunotherapy, which I call OIT for short. OIT is a little different. So Xolair treats all of your food allergies in some way, and OIT just treats one food at a time. But essentially, OIT is a treatment for food allergy where if you can tolerate a very small amount of the allergen, which we figure out based on a food challenge, then we start giving you a daily dose of the food you're allergic to every day. We slowly increase that amount over time, and then you continue on that dose, we say indefinitely. The really cool thing about OIT is that it can potentially help your child outgrow their allergy. It is not a guarantee. It can just increase the potential for them to outgrow. Different factors are involved. So the younger they are, the more likely that they could potentially outgrow. Their numbers, their allergy numbers in the blood also are a factor. But OIT is really amazing and can be helpful in terms of several different facets of allergy. Um, and something that we just really enjoy doing, especially when we have good outcomes. So even if you don't outgrow your allergy on OIT, we know that regardless, you do achieve protection. So similar to the Xolair, where if you take a bite of the food that we're treating, so if we're treating peanut, accidentally take a bite of a peanut butter cup and you thought it was a sun butter cup, I'm expecting a much milder reaction, if any at all, than if you had taken that same bite before starting OIT. So that is just my little tidbit on food allergy. Again, the focus was really pollen, but I wanted to make sure to bring up a little bit of food allergy just in case anyone had a particular interest. That is everything that I wanted to talk about today. Thank you so much for your attention. And if there are any questions.
Thank you so much. That was great. We can open the floor to questions. If people have any questions, they can put it in the Q&A portal. I have a couple questions while we're waiting for other questions to come in. If a child has eczema or sensitive skin, do the skin testing, can that be not a false positive, but is the skin testing still effective for treating allergens?
That's a great question. So if you have eczema, particularly like on your arms, we have to be a little careful about where we do the testing. But it sounds like you're asking, like, will they be more reactive or is their testing reliable? And so that's why we do the positive and negative controls. So sensitive skin, if you are very sensitive or if your eczema is acting up, then I would expect the saline, my negative control, to pop up. And so if that were the case, then I would say, you know what, I can't really trust my testing today. So what that would mean is I would then have the patient come back at a later date and we could repeat the skin testing, or alternatively, I could offer blood testing, which would not be affected, obviously, by the skin itself.
Okay. Here's a question. My grandson is 20 months. Can he have antihistamines?
Yep, absolutely. So we give antihistamines to little ones all the time. You can give Zyrtec and Benadryl. A lot of pediatricians feel most comfortable with Benadryl, so they'll probably give you dosing for Benadryl. But I feel completely comfortable having a 20-month-old take Zyrtec as well. There is dosing for children under 2 years old.
Is there an age that kids will start to show allergies, or they'll be kind of done showing allergies? Or is it something that just constantly can happen?
Yeah, so that's a great question. So food allergies, primarily you are born with your food allergy. Now there's some different food allergies that can pop up later in life that can be related to pollen allergy, but that's a little bit more complicated. But for like a peanut allergy or an egg allergy, your child was born with that. And it might just take the first 1 to 3 ingestions for us to discover that they have an allergy. Seasonal allergies or environmental allergies, they can sort of wax and wane over time. Like they do, like I mentioned, specifically for the seasonal allergies, take a few seasons to develop. But other allergies, things like dusts and molds, they can come on later in life. And then I also have patients that say that they used to be really bad and they got better. So there's some waxing and waning that happens. Food allergies, like I said, not expecting a ton of food allergies to come on later in life unless they're those atypical pollen related ones. But environmental allergies can be a little bit more of a mixed bag.
Okay. And the food sensitivity versus food allergy.
Mhm.
When you said kind of having a reaction, is like a lot of people will say they're lactose intolerant, or is
Mhm.
that really an allergy, or is it exposure, or
That is a great question. So this comes up a lot. Um, Specifically lactose intolerance and gluten or celiac intolerant or celiac disease or gluten intolerance. So they're actually two different things. So celiac and lactose intolerance are diagnosed, managed, and treated by GI doctors. Um, in terms of like a lactose intolerance, it's a different presentation. So basically, if you have a milk allergy, your child might take a bite of yogurt, break out into hives, have wheezing and vomiting. If your child loves ice cream and they eat ice cream all the time, but every time they eat ice cream, they say, Mom, my belly hurts, I have crampy belly pain, maybe they have loose stools. Clinically, that sounds a lot more like a lactose intolerance. And so, for that particular child, given that they still have milk and dairy in their diet, and they haven't had any of those other symptoms, that's the person I would send to a GI to have them evaluated for lactose intolerance. Similar is the celiac or gluten intolerance, where kids have things that contain gluten, wheat, etc. And same thing, they have maybe bloating, stomach discomfort. They can have other vague symptoms that we would also have you see a GI doctor. But you can have an allergy to wheat, same way that you can have an allergy to milk, just like a peanut allergy, again, where you take a bite of pasta, break out into hives, have wheezing, vomiting, whatever it may be. So that's different, but definitely something that we talk about often.
okay? And my last question, if there aren't any others coming through, was asthma. Is asthma triggered by allergies, or is it just a condition? Or I don't know anything about asthma, so I was curious.
Yeah, no, definitely. That's a great question. Asthma is definitely now a child is probably prone to having asthma to begin with. Um, like I have some kids that I've met that have no allergies but just have asthma. But a lot of kids, asthma can be triggered. Like it is worse during the pollen season, or it is worse during some particular time of year that their seasonal allergies or other allergies are acting up. So we do work really closely with the pulmonologists. You know, we treat some asthma and some that doesn't really have an allergic component. I would still have see a pulmonologist, but it's definitely something where when the pulmonologist meets someone, they also want to know if the child has allergies so that we can appropriately add these allergy medicines on to help treat both components of the asthma to make sure that we're fully treating the child's breathing troubles.
Great. Thank you so much.
No
I don't
problem.
see any more questions coming through. So
Great.
um, I, I'd just like to thank Caitlin for her time this evening. And I'd also like to remind everyone